Chapter 36, Disorders of Neuromuscular Function. So in this chapter, we're going to do a brief review of the central nervous system. The central nervous system, which consists of the brain and the spinal cord, and the fundamental unit of the nervous system is the neuron or the nerve cell. And this nerve cell is a highly specialized conductor cell that receives and transmits electrochemical nerve impulses through nerve fibers to make the body work in the way that it needs to. We have two motor systems, the extrapyramidal and the pyramidal. So think of extrapyramidal as the fibers go to the same side of the body, where the pyramidal fibers cross over to the other side of the body to control that. The extrapyramidal system mainly deals with gross movement, and it provides basically a framework for how the nervous system works. Think about the extrapyramidal system as involuntary movement and related to muscle rigidity or immobilization with paralysis. The pyramidal system, which is the one that crosses over, is what helps create our fine motor movement and our delicate motor movement. Think about diseases that hit this system in terms of spasticity and paralysis. Both of these motor systems can be adversely affected by the side effects or adverse reactions of medications, in addition to injury and chronic disease. The upper motor neuron cell bodies are in the motor cortex, and they send their axons down through the internal capsule and then into the white matter of the spinal cord. Think of these as your spinal reflexes that help coordinate involuntary motor responses for survival. Lots of vocabulary words in this chapter. So when we speak about muscle tone and muscle tone related to nerve innervation, we use these terms that you see here on the slide. These are the words that we use to describe the abnormalities that we see. Hypotonia means that we have less than normal muscle tension. Flaccidity means we have total absence of any kind of muscle tone. Hypertonia would mean hypertonia, rigidity, and clonus are all ways to describe progressively more significant, higher than normal muscle tone. More vocabulary words to describe motor dysfunction. Plegia, meaning stroke or paralysis. Paralysis, meaning loss of movement. Paresis, meaning weakness. Mono, one limb. Hemi, both limbs on one side. So hemi is one side. Di or para means both upper or both lower limbs. Quad or tetra mean all four limbs being involved. When we have upper motor neuron damage, this results in weakness and loss of voluntary motion. The spinal reflexes may remain intact, but they cannot be activated or modulated by the brain. So when we see upper motor neuron damage, we generally see an increased muscle tone, so more of that spasticity, clonus, hyperreflexia, then we see flaccidness. In lower motor neuron damage, the neurons that directly innervate the muscles are affected. This can be affected by having irritated neurons. So you see spontaneous muscle contractions or fasciculations where you see involuntary movement happening without active motor control of the brain. Or this can occur because of death of neurons, such as having total loss of your spinal reflexes. And basically this results in a flaccid paralysis and a progressive atrophy of the muscles because the innervation isn't happening to keep your muscles toned. Point-blank skeletal muscle problems are usually related to disuse or denervation. And basically what happens to the muscles is they atrophy because they're not being used. In some disease processes such as MS or muscular dystrophy, the proteins that are actually in the muscles that help the muscles collapse and contract are not properly attached to the cytoskeleton, and that means there's no voluntary control, or the voluntary control does not happen the way that it's supposed to. In muscular dystrophy as a disease process, and this is a genetic disorder where this degeneration of the skeletal muscle fibers becomes progressive, and the muscle fibers are actually replaced with fat and connective tissue. This results in muscle weakness, and this gets progressively worse and more widespread so that it attacks the respiratory muscles, which makes all the protective mechanisms within the respiratory system, such as cough reflex and things like that, less able to function. Also, the heart is a muscle tissue, so you get cardiomyopathy where it just can't contract as strong as we would like it to. And you also get bowel and bladder weakness, resulting in potential incontinence. Last but not least, if we don't provide passive range of motion to the muscles, you will get contractures from the lack of use. In the nervous system, we can get disorders that center around the blockage of acetylcholine, which helps with the transmission of nerve signals. Or we can get the effect on muscle cells, such as in Myasthenia Gravis, or in some of the medications that we give to help relax the respiratory system. Or this can happen as a result of environmental exposure to organophosphates. In the disease Myasthenia Gravis, the neuromuscular junctions are totally destroyed. This is an autoimmune disease that gradually destructs the acetylcholine receptors and is oftentimes associated with a tumor in the thymus area. The signs and symptoms start out gradually with development of weakness from proximal to distal portions of the body. Women are 3 times more likely than men to have this happen to them. This is also a disease of the younger generation, so people less than 40 years old. Signs and symptoms include muscle weakness, easy fatigue, limb weakness, particularly when lifting objects or climbing stairs, along with chewing and swallowing disorders. What you see here is when they get up in the morning, they are at their peak because of the rest from overnight, and then progressive weakness occurs as the day progresses. Myasthenia crisis is one of the adverse effects of the disease process where hypoxia, tachycardia, and respiratory distress occurs because of the muscle weakness. And the way that we treat this is we put the patient on a ventilator to support respirations. Myasthenia crisis is usually exacerbated by stress on the body, which could be anything from, regular day-to-day stress to infection, pregnancy, or surgery. Another type of crisis that occurs with myasthenia gravis is a cholinergic crisis, and this is where we would see severe drops in the blood pressure, slowing of the heart rhythm, and increased respiratory secretions because the mechanisms are not working to get the secretions out. Again, another emergency type situation. So people who have myasthenia gravis are frequent flyers within the hospital system as their body becomes more and more stressed with the destruction of the acetylcholine receptors. How do we treat this? Immunosuppressive therapy, again, because we think it's an autoimmune disease. We try to decrease the self-attack. We can give anticholinergistic drugs to break down the acetylcholine at the junction to improve the function. Steroids to decrease the inflammatory response, and the plasmapheresis. Sometimes we use that where we take the blood out and filter it through, kind of like dialysis, but a little bit different, to remove the antibodies in the blood and decrease the seriousness or severity of the attack. Know that some medications aggravate myasthenia gravis, and one class of medications would be the aminoglycoside antibiotics. Spinal cord injury can be caused by a variety of things. Immediate damage to the actual spinal cord results in spinal cord shock and temporary or complete loss of function below the level of injury. But spinal cord injury can also be secondary, related to neuron or white matter damage, damage to the blood vessels that supply a certain area, or the vasomotor tone, decreasing that blood supply. So know that spinal cord injury is not always due to trauma as we most often think of it. You can have complete spinal cord injury where there's absolutely no function below the level of injury, or you can have a partial spinal cord injury, which means that there are still motor pathways and neuron pathways that exist. If it's damage to the axons near the gray matter in the central cord, the arms are more affected than the legs. If it's in the anterior cord placement, we have motor function is affected, but the touch sensation is not affected. So I would still be able to feel, but I wouldn't be able to voluntarily move my limbs. And then there's partial spinal cord injury where we call it the Brown-Séquard syndrome, where there's damage to one side of the cord, and there's a total motor function loss on that side, but there's a pain and temperature sensation loss from the opposite side. So it just gets the brain confused. Just some nice pictures to show you the different kinds of the location of where the spinal cord injury is and what areas it affects in terms of partial motor and sensation loss or complete motor and sensation loss. Again, take a look and review pages 918 with a chart 36-1, and on page 920, table 36-2. We'll give you some more good visuals here. It's important that you understand what motor neurons do at the varying levels of the spinal cord. That's probably the most important thing to take away. So if I have damage to T12 and above, my spinal reflexes will still work, but will not be modulated by my brain. And I will have the hypertonia or spastic paralysis that we've talked about. If I have injury to the lower motor neurons, so that's T12 and below, I get more of a flaccid paralysis. And this is where you see people wearing braces to support their flexion. There are three common issues that occur in the sympathetic or autonomic nervous system below the level of the injury. Oftentimes we will get a vasovagal response without trying. Postural hypotension is another problem that tends to affect spinal cord injury or spinal cord trauma patients frequently. And then the emergency of autonomic dysreflexia. So the mechanism of autonomic dysreflexia is that it is an acute episode, and it happens unpredictably during the first year after the spinal cord injury. It is an emergency type situation. First level early signs and symptoms are vasospasm, hypertension, a paling of the skin with goosebumps. If that is not recognized, the body goes into a second level of dysfunction where the heart slows, you get a bradycardia, you become profusely diaphoretic, a headache, and the skin becomes flushed at this point. Lastly, but not, and the most severe symptoms are you will have convulsions and possibly death if not recognized. One of the main stimuli of autonomic dysreflexia is either a full bladder or a full rectum. So if you are working on a unit that takes care of newly diagnosed spinal cord injuries, you will find that the nurses on those units are very attentive to bowel and bladder monitoring, and that's one of the very important monitoring aspects of this patient population. Additionally, you will see that patients must wear binders and TED hose to promote to keep the blood pressure up. And when you remove these binders and TED hose, the blood pressure may